very nice to have you here. And, look forward to your presentation.
Thank you. I'm really and I am so, Glomerulonephritis is a disease I think all of us see, and sometimes, and then there's a lot of research and a lot of things are going on in this disease, but still we are not sure how to actually treat this disease. So I will start with a case. This is a case of 25-year-old male who presented to us way back in 2014 with swelling of 2016 with swelling of lower limb and puffiness for 2 months, and his creatinine was 1.6. The nephrotic range proteinuria, active urinary sediment, normal or slightly increased kidney size, and C3 was low in this patient. The next step in this patient is obviously you will go for biopsy, and so I'm not an expert in biopsy, but I could say there's a lobar expectoration, and there was some chronicity of the 19 gram per fluorose, and there was duplication of the basement membrane, and there was C3 plus post-cellular, which confirms the diagnosis of the C3 glomerulopathy. So what next and how we should treat this patient? That's the question in mind of nephrologists when seeing such a patient. We'll discuss about that. Just a brief about the historical perspective of chronic glomerulonephritis. It was first described in 1962 with glomerulonephritis with hypocomplementemia, and then deposit disease, and later on first described in 1973, which was identified by electron microscopy. Subsequently, the isolated C3 deposits were seen first in 2007 and 2013. There was classification of the C3 glomerulopathy was done, and there was a consensus report, and then this entity got separated with the NPGN. So why there is a different terminology? We know the classical NPGN type 1, 2, and 3 NPGN type 1. There is a based on the deposit, whether you have NPGN pattern, and there's a mesangial interventricular deposit. NPGN type 2 is the intramembranous deposit, and type 3 there is sub-epithelial deposit in addition to the mesangial and subendothelial deposit. But then this classification actually does not tell about the immune complexes mediated from complement mediated NPGN, and that is why when there is staining for the C3 alone, that has been separately classified as a C3 glomerulopathy. So to simplify it, if you have an NPGN pattern of injury, there is an isolated C3 deposit, that is C3 glomerulopathy, and that is subdivided into DDD and C3 glomerulonephritis based on the electron microscopy. And if you have immune complex, then it could be various other things like autoimmune diseases like SLE, rheumatoid arthritis, or infections, viral infections, or monoclonal glomerulopathy. These are the things which you should look for when there is an immune complex along with C3 deposition. So that is the umbrella of the C3 glomerulopathy, DDD and C3GN. This disease, C3GN, is a rare disease and heterogeneous entity. I will describe how it is heterogeneous, and there is a dysregulation of the alternative pathway of the alternative complement, and there is either a genetic or acquired alteration in the pathway, and it is defined either the presence of the positive glomerular immunofluorescence for C3 isolated or at least 2 orders of magnitude greater than the rest of the immune reaction. So that is how we define C3GN currently, and mainly the DDD is seen in the younger individual and C3GN in the older, but then anything can be seen at any age, but predominantly there is an age difference, and it is, as I said, it's a rare disease with prevalence of 1 to 2 per million population. This is in US and Europe, they say it is even less, and South Asia in one study they found to 1.52% of all the diseases. As I told, this is a disease of the alternate pathway alteration, and classical leptin pathway has nothing to do with this disease. An alternate pathway is the spontaneous takeover, which keeps on trickling C3 converted to hydrolyze to the C3 hydroxy H2O, and then this C3 acted upon by which convert the complement factor B to form a alternate pathway C3 convertase, and which further convert C3 into C3A and B, and then it takes the C5 convertase, and then there is a membrane attack complex, which is in the brief pathophysiology of this. And there are many regulator actually which work in this pathway. So these on the right side are the factors B or CC nephritis factor or other factors which can actually continue to stimulate the convertases, alternate pathway convertases, and these are some of the regulatory proteins: factor H, I, decastylating factor, NCP, complement regulatory proteins. These actually inhibit the conversion of the alternate so that it does not overactivate. So if there is an overactivation of the right side of the pathway, can lead to the formation of the continued activity of the alternate complement pathway. So alternate complement pathway dysregulation is a central event. It can be genetic or it could be acquired. Genetic abnormalities are seen only in a quarter of patients with C3G, mainly the factor C3, complement factor B, H, I, or the factor H related protein. There is some rearrangement because the factor H related protein, they are basically do competitive inhibition with complement factor H, and that is why if there is a overactivity of these, then they can actually decrease the inhibitory roles of the complement factor H, leading to the development of the alternate pathway activation. But the major abnormality in these patients is the presence of the autoantibodies. Basically, most commonly the C3 nephritis factor, which is seen in 50 to 80% patients with C3 and DDD. Mostly 80% cases of DDD and 50% cases of C3 glomerulonephritis. Then there could be C3 nephrotic, C4, C5, and other antibodies which are also found in these patients, not so commonly. Mainly the C3 nephritis factor and C5 nephritis factor, which are most important antibodies found in these patients. How do we diagnose this disease? So clinical presentation, serology, kidney biopsy, immunological tests, and the genetic test. These are the various steps whether we look for the diagnosis of this patient, these patients. So the most common presentation of these patients is either hematuria or proteinuria, which is seen in vast majority of the patients. 80 to 90% of the patients can have the hematuria or proteinuria, but then they can other features like nephrotic syndrome, nephritic syndrome, AKI, and RPRR. So any sort of presentation can occur in patients with C3G. Sometimes extra-renal manifestation also occurs, but that is seen only in the cases of DDD, mainly ocular descent, where the complement containing filtration find in the bush membrane of the retina, and the partial lipodystrophy due to the symmetrical loss of fat. But this is seen in cases of the dense deposit disease. Coming to serology and immunological tests, low serum C3 is the hallmark of the characteristic, but it is not seen in all the patients. Only 50 to 70%, more so in the DDD as compared to C3 glomerulonephritis. Then autoantibody screening is very important. As I mentioned, 50 to 80% of these patients have autoantibody C3 or C5 nephritis factor. Functional assays should be done to see the complement activity TH50 and T5T9 levels, and paraprotein estimation is very important. More than 60 years of age, in a series of Mayo Clinic of more than 100 patients, they found that more than 50 years of age, 65% of patients had paraproteinemia. I am not sure how many of our patients had, but this should always be done in patients with C3G. The kidney biopsy can have multitude of features. So membranoproliferative is the most common, but then you can have within the proliferative endocapillary eccentric or non-specific finding in light microscopy, and these deposits stain for the shown negative for John methanamine silver stain and red on methanol. EM is essential currently for the diagnosis to differentiate between dense deposit disease and C3G. depending on the type of the deposit and whether it's DDD or PCG. So this coming back to our patient, so this patient then he did an electron microscopy, and this is a not very clearly seen. So I tell the report this patient had DDD. There is a hyper-eosinophilic deposit with linear fashion seen around the GBM in this patient and reported at DDD. So this is how you actually, this is a photograph which shows that how you find this is a DDD and this is a PCG and different in the deposit in both the diseases. So genetic testing is important in these patients. There could be multiple, so one is acquired like antibodies. You should have QC nephritic tester, complement regulator antibodies against these, although less common. And then you can have mutationally complement regulators like S, I, MCP, and complement sector regulated protein, allele variation, and mutation in the C3, which is the initial part of the complement activation system. So we did genetic testing in our patient, and this was the next generation sequencing, and I'm not sure what is the diagnosis based on. There are multiple mutations which has been detected from IGA Nephropathy to HUS and this thing. So in these patients, you need to do MLPA to find the exact mutation or the genetic abnormality, and we found there is some susceptibility allele associated with phenotype. This actually was a case of DDD, and DDD has a very high rate of recurrence after transplant. Patient was interested in transplant, but he hold it. Just as the previous speaker has mentioned that you should be able to differentiate CCGN for the two entities important. One is the immune complex GN, whether you need to do this immunofluorescence, and sometimes even you need to give pronase to unmask the other immune complexes. That is important, so you don't miss mainly the paraproteinemia. And second important differential diagnosis is post-infectious GN, because sometimes there could be, in the later stages of the recovery, there could be only C3 deposits in patients with post-infectious GN, and apart from reverse and DNA, there is no other specific marker, so you have to wait for 8 to 12 weeks. If persistently low C3 occurs, then you have to maybe adjust your diagnosis to C3 GN as compared to post-infectious GN. Sometimes you get an initial picture which is same in both these patients. So what is the prognosis? 70 to 80% ESRD in children within 10 years, 50% adults in 10 years, and post-transplant recurrence more than graft loss is 50%. So this is a difficult disease, high chances of recurrence. Recurrence, the predictor of the worst prognosis, a higher risk of C3G, lower baseline GFR, and higher baseline proteinuria. These are the predictor of the worst prognosis. Histology. How do you treat this patient or these patients? So this is a KDIGO guidelines in 2021. So if you have a patient who has proteinuria and no other manifestation, proteinuria more than 1 gram, you first optimize with AC inhibitor, ARB, and other conservative treatment, control the blood pressure, and with that, if there is improvement, then no additional treatment is required. However, if patient has moderate to severe disease with deteriorating renal function, necrotic pain with proteinuria, you have to give corticosteroid and MMS, and then you can give eculizumab, or you can put on some of the clinical trials. So, corticosteroid and MMS, what is the evidence for using this? So, this is a study from the Spanish group in 2015. They taken 61 patients, and there were 3 groups, 20 patients each, roughly in each of the group. In one group they gave steroid plus MMF, one group steroid alone or other immunosuppression, and one group placebo only. And there was improvement in these patients who received corticosteroid plus MMF. But the problem with this study was there were few patients who had genetic workup, and effect was better in those patients who had C3 nephritis factor positive. If we see the other studies, or many studies have been done with the immunosuppression, and we find there is a mixed result. So as you see complete remission is seen in some of the patients, partial remission in some of the patients, but then results are mixed. In some study, there is no actually benefit of giving these steroid and MMF, but as I say, 40 to 50% benefit in some of these studies. This is again analysis of the large data of more than about 97 patients, retrospective analysis, and they found that patients who received steroids, they had higher chances of remission and lesser chances of kidney failure as compared to other immunosuppression or no immunosuppression, and the response was better in those patients who had C3 nephritic factor as compared to those patients who had pathologic genetic variant, and at the best in those patients you can only achieve the partial remission. So this shows that because 50 to 80% of the patients, they have these other antibodies. So if you can try even without the genetic, ideally you should have a genetic buffer, but you can try steroid and MMS combination as a first line treatment in many of these patients who have progressive renal function decline or nephrotic proteinuria. There are newer therapy which is now available. So 4 of 5 actually I will discuss. So these are the one is Podocytopathy, which affects the C3, which is a C3 inhibitor, Iptacopan, the factor B inhibitor, Danicopan, factor D, Avacopan, C5 receptor blocker, and Eculizumab, which is the oldest molecule available, and which is such inverse conversion of C5 to C5A and B. And so Eculizumab has been used for this. We all know about Eculizumab, which is a monoclonal antibody and involved in the binding of the alternate pathways C5 convertase and prevent the cleavage of C5 to C5A and B. And it has been already approved for PNH and atypical HUS. We all know that. So that is the reason behind, because this is also alternate pathway complement dysregulation. So there were 2 or 3 studies have been done. The initial study involved 6 patients and 3 patients each with DDD and C3GN, and they found 4 out of these patients had favorable response. 2 patients had improvement in renal function, reduction in proteinuria, and 1 patient physiological improvement. This is the initial study which was published in 2018 or something, and then there was a French study of 26 patients which received various immunosuppression, included both children and adults, and these patients received Eculizumab treatment for a median duration of 14 months, and 12 out of 26 had shown some partial or the complete response, and 14 did not show. So mixed response was seen, and one of the reasons could be that because Eculizumab affects the later stages when the conversion of the C5 to C5A and B. But if you see in the C3GN, there is an initial C3 convertase, initial pathways are also involved. So that is why it might not be so effective. And currently it is used as an off-label indication, off-label drug for the treatment of C3GN. Then coming to the other agent, Iptacopan, Danicopan, Iptacopan, and Avacopan, which I just mentioned. So one study of each of this. So Iptacopan, this is a C3 inhibitor. This was the initial pilot phase 2 study, which was done in 7 patients, and they give for 24 weeks they give 360 milligram per day, and then 1080 milligrams for twice weekly, and then there was extension phase in one of these patients and the observation safety follow-up, and they found that intention to treat analysis 50% proteinuria reduction at 1 year, and there was increase in serum C3 and plasma C5b9 levels, decrease in plasma C5b levels with this drug. So good result, encouraging result, and now a phase 3 study is going on, which is a valiant study to recruit 90 participants. Second is Danicopan, which is a factor D inhibitor. The initial phase 2 trial which was done did not find actually a good result, and the authors concluded that you need, because the complement inhibition was not actually complete with the factor D, the doses which they have given. and the end result could not be achieved. And currently there are no new trials are going on with Denigapan in C3G. Coming to iptacopan, this is a factor B inhibitor, and this is a phase 2 trial. 27 patients, both native cohort and the recurrent kidney transplant patients, and there was significant reduction in proteinuria, C3 deposit score, improvement in the C3 level, complement activity, and no death during the study. So the iptacopan has been now there's a phase 3 trial is going on for the iptacopan from the C3GN, which is going underway. And then avacopan, which is a C5 receptor blocker, and there's a phase 2 RCT. This is published as an abstract, so no full publication is available. There's again benefits of using avacopan and significant decrease in UPCR. So coming back to our cases based on this, so that time when we started treating this patient, so we obviously had one choice, with steroid plus MMF, and we started, and with that there was significant improvement. You can see over a period of 1 year, proteinuria decreased significantly. There was not much progression of renal dysfunction, but after 1 year he developed infection, started developing infection despite tapering of steroids, and patient was maintained on low doses of MMF, and this has to be discontinued, and then patient was maintained on the conservative therapy, ACE inhibitor, ARBs, and then gradually proteinuria started also increasing, and then he had a rapid worsening in 2023 and initiated on dialysis in March 24. Now patient want to go for transplant, so how, whether we should transplant this patient, what is the data and evidence? So will you transplant this patient? So how many of you will do transplant of this patient? We'll discuss all that. This is the case of dense deposit disease. This is not a case of C3 glomerulonephritis. So the recurrence. So as you can see, the Dr. Gulati yesterday discussed about recurrence. You can see the C3GN and GDD is the most recurrent disease. Recurrence rate of 50 to 80% are seen in patients who have C3GN or GDD. And there is very poor graph. This is a UNOS 10-year survival, 11% in pediatric and 20% in adult. And this is a sum of the data. This is a study in 2018, 19 participants with C3GN 12 and 7, 80% recurrence rate and poor allograft survival. Systemic review in 2020, 12 studies, 122 patients. Allograft failure 33% with eculizumab, 42% with plasma exchange, 81% with rituximab. So this is the failure rate even despite using the currently available, and I don't think we have current freely available eculizumab. A lot of patients can afford, and all other drugs are still in the experimental stages. But sometimes actually we don't know. And that sometimes missed, and you do transplant in some of these patients and you find out. So this is a patient with C3GN. We diagnosed this later. He came to us in 2014 and underwent transplant in 2015 with mother as a donor. He had a stable graft function over the next 3 months, but after 3-4 months he started developing rise in creatinine, proteinuria, and no history of non-compliance with medication. So we did a graft biopsy, and you can see in this biopsy there is a lobular accentuation, there is a neutrophilic glomerulitis, and C3 was 3 plus and C40 was negative. This initial biopsy report actually reported as CGN with FHES, but if you see closely this patient, they had shown there is a staining of C3 with moderate intensity. So this was basically C3 glomerulonephritis. This patient from beginning, and this is the recurrence of C3GN in this patient. High immunoglobulins are negative, so reporting was wrong. This was a C3GN case of C3GN, and we did the genetic analysis of the antibody screening, and we found this patient has C3 nephritic factor which was positive in this patient. So we at that time we did not have anything else to give, so we increased the steroid and then gradually tapered over a period of 3 to 6 months and kept in on the slightly higher doses of steroid. And for last follow up with me was only a month back, and it's creatinine 2.8. This dark function is still functioning over a period of 9 years. And this patient actually emergency had to be changed because of persistent GI symptoms, take as an steroid with ARVs, and who is doing as well as possible. So we'll discuss about first case that next case that I presented, whether we should do transplant. I would not do transplant in this patient because that is a DDD and this was a CCGN with nephritis factor. So to take home any patient which is reported NPGN or any polycystic glomerulonephritis should be evaluated for C3 glomerulopathy, and I think most of the patients we now started sending EM for every patient because obviously the later on it's very difficult to get the good tissue and many of patients will miss if you are not doing the EM. And MPGN with immunoglobulin, you should do a thorough search for the secondary causes. Detailed complement and genetic analysis should be done in patients with CCGN. The MF and steroid are the first line agent. Transplant patients should be conscious regarding high risk of recurrence. And the transplant should only be done if there is a retransplant, if there is a access to novel anti-complement agent or eculizumab. I am not sure about this. This is a question mark. Thank you. Thank you very much for your attention.
So Dr. Shyam, thanks for that excellent lecture on CPGN. A couple of points that I would want you to elaborate on. A patient lands with you with small shrunken kidneys without a biopsy. How do you suspect that the patient may have a CPGN like etiology and decide on whether to transplant them?
Yeah, so this is a actually problem we all face because many of our patients land like this. So one thing is that in all patients with workup, I do C3 levels in all patients with PSRD, and if the C3 levels are significantly low, if they might be low, then it's okay, but significantly low, then one should send the genetic analysis of these patients to find out whether they have any genetic abnormality. Otherwise, you can actually miss out DDD or some of the diseases. The second actually dilemma comes when there is a report comes which shows the susceptibility of allele or some variant of unknown significance. Then you have to take a call depending on the patient's risk appetite whether you would like to transplant this patient or not. So that is actually further. Sometimes you do genetic analysis and then you are more in dilemma rather than solving the problem. But obviously, I would approach this.
Second follow-up question to the same is that in patients with a C3 glomerulonephritis, is there any reason why they behave different, like clinical manifestations? Some of them you see they are stable with a proteinuria less than a gram, not requiring immunotherapy. On the other hand, there are some patients who have a rapidly progressive cold. So any way we can know who will go for which course?
So that is actually, that happens in many diseases. If you see glomerulonephritis, IGA Nephropathy, I think it depends on the basic pathophysiology mechanism which is underlying. If there is a mild alternate pathway dysregulation or severe, or we don't know that. But then there is a variety of presentation of every. Some patients with diabetes develop diabetic kidney disease, while other patients with no control, they never develop. So I think we don't know many of these answers.
That's all we are showing. Yeah. before the complement arrives. This transplant is going to be elective. Some did that and so So denying transplant or disease.
Yeah. So it is okay if you don't know about it. Like we did transplant in that patient. If such type of patient comes again, I will do the genetic workup, auto-antibody workup. If he is C3 nephritic factor or C5 nephritic factor positive, and there is no mutation in the complement gene, then I will go for transplant. But if he has DDD and there is a mutation in the one of the complement genes, then I will not do the transplant in this patient. So yeah. So as if you have the mutation complement factor H or I or C3, then I would not transplant these patients. If you have autoantibodies or there is some rearrangement in complement factor H protein and TFH, and which is not sure because many of our normal population also have some of these things, then I would explain in this I will do. So I will not deny transplant to 70% of patients. For 30% or 20% of patients, I would be cautious like in our patients. DDD clear cut proven rapid this the latest patient, not one. Like if I get a patient like this, we transplant it, I will transplant it. I will not say it.
I think very well said, Shyam. This is still, I think, one more question we have.
So I skipped that part. So there was a few case reports of plasmapheresis in C3GN, but then there are only case report and it is not a recommended treatment for, there is no data to support it. Only case reports 5 or 10 years back. Nowadays plasmapheresis is not actually advised as a treatment for C3GN.
How do you suppose this you suppose you use a galactoside, which is a C5A inhibitor, and blocking the disease is actually a mass activity. I'm not trying to understand C5A inhibitors are actually useful in this situation.
So there is only one phase 2 study has happened. So basically, ultimately, you block this C5A conversion to C5A and B and the in-between membrane attack complex, and which is the final stage of the lysis by the complement. As by eculizumab, you find that some of the patients there is a response rate of 40 to 50% patients. So some of the patients they respond to. So likewise, some of the patients, but these are only patient studies with 10 to 15 or even less patients. So unless we have phase 3 study and we have more data and to support this, we can't really say. But mechanistic wise, it is been useful, but it obviously in upfront will not inhibit. So the most promising therapy I would say at this stage would be the initial. There's a recent report which I have not mentioned it. This Tacopan has been used in 3 patients with recurrent C3GN, and they all all of those improved. So this has been actually being approved for treatment of recurrent C3GN, only a case report of 3 patients. For combined liver kidney transplantation, liver transplantation is not easy. Actually, it's a very difficult thing. Combined liver kidney transplant, I don't know, but at our center is a big center for combined liver transplant. There is a 40 to 50% failure rate initial, and it's very costly. So I would not go for combined liver kidney transplant in this patient only for PH1 or maybe AHUS. If you don't have actually even AHUS, they say nowadays you go for eculizumab rather than combined liver kidney transplant. It's a risky thing. 40% mortality. Whatever they say, but then this is a 40% mortality.
Yes.